Well, it's an honor to be here, and I appreciate that everybody's still lasting through to my talk. Excited and grateful to the organizers for the invitation to be here. My name is Dr. Carraway, and I work at the Cleveland Clinic, and I specialize in managing patients with myelodysplastic syndromes and also acute leukemias. It's wonderful to meet you all. The objectives that I put forth for today is to really talk more about some of the influence of the mutations that you've been hearing about on our prognostic scoring system. We'll highlight the current standard of care and discuss emerging therapies, review some of the targeted based studies and therapies that are options, and also briefly discuss some of the unmet challenges and future directions in this space. As we've already talked about, we know that MDS is a group of heterogeneous clonal hematopoietic cell neoplasms, and it's associated with a hypercellular bone marrow biopsy, peripheral blood cytopenias, and a variable risk of progression to AML, as Dr. Halpern just walked us through. You can see here that the overall incidence is 5 per 100,000, and it's the most common myeloid neoplasm. On the right of the screen, you can see the incidence rises with age. You can see, as Dr. Scott pointed out to us, that it affects males more than females, with the males in the orange boxes and the females in the gray. The majority of patients diagnosed with MDS are over the age of 60. And for many of the patients that present with MDS, the majority of the presentation has to do with anemia. So about 80 to 90% of the time. And about 60% of the time, or 2/3 of the time, patients present with a low risk MDS. And we'll talk through the management of both low risk MDS and high risk MDS throughout the presentation. So we always start with why. Why should we care about these myeloid diseases? As we just talked about, we know that it's a problem that is emerging. We have an aging population, and we expect that MDS will affect more people because we have more people around that are living longer and surviving their first cancers. The treatment of MDS can delay time to AML and increase overall survival. And so that's actually really important and meaningful. One of the things, because of the research that we've done in the mutational space, is that we're able to identify these mutations earlier before patients are even diagnosed with MDS. So there are these entities that we haven't yet talked about today called CHIP and CCUS, where these mutations are able to be identified in patients that have a normal count, that are not symptomatic. And these mutations are classically DNMT3A, TET2, and ASXL1, which we refer to as DTA mutations. And we know that the existence of these mutations in patients over the age of 70 are associated with an increased risk of cardiac events, stroke, as well as increased likelihood of hematologic malignancies. So the idea here is that if we can identify these lesions sooner, are there things that we can do to decrease someone's risk of heart disease and even decrease the risk of progression to hematologic malignancies? So not only talking about how do we treat these things when they come, but can we prevent them in the first place? When you see this word CCUS, or clonal cytopenia of undetermined significance, it's when there are counts that are low, like a low white count, a low hemoglobin, or a low platelet, and the presence of one of these mutations. So there's a lot of research going on in this space with regard to this. And you can see on the left side of the screen, when we put these mutations in mice in specific studies, you can see that when we have a knockout model, that's when the full mutation is there. And when you have this mutation of TET2, you can see that there are lesions in the vessel wall that is atherosclerosis or heart disease. And you can see the lesion size is increased when you have this mutation present in its full form, and the number of lesions is much higher when we have those mutations. And in the cardiac space, we know that there are patients that have heart disease and present with an MI, and they decided to start using a medication called canakinumab, which is an anti-IL-1 therapy in those patients that are TET2 mutated. And using that drug, they were able to decrease the frequency of myeloid-associated cardiac events in patients that previously had had heart attacks. So we think that these types of therapies are meaningful not just for patients with heart disease, but potentially could be useful for patients in terms of progression to MDS. So I think this is very exciting and shows that the information that we're getting with regard to mutational phenotype is really central to the diagnosis and important for us to continue studying. Now, with regard to clonal hematopoiesis, we know that we see these mutations as patients age, and it gets a little confusing. You can see that there's a lot of related diseases, such as COPD and smoking. Maybe that causes more mutations, or even chronic inflammation like rheumatologic diseases or chronic kidney disease. So there's lots of questions, not just about are there relations of these mutations to heart disease and hematologic malignancies, but other entities that also are associated with inflammation. And so this is the term that we're calling inflammaging. There's data that was presented in a number of years ago looking at these mutations and having a benefit or a decrease of Alzheimer's disease. So it gets a little confusing. So are these mutations good? Can they be protective for people? Maybe so with Alzheimer's, but they're certainly not so protective in the heart disease realm, nor in the realm of hemalignancies. The other thing that I will share is that there are new entities that are being identified with new mutations that we never knew about. So just as Dr. Scott was talking about, there are these overlap syndromes of aplastic anemia and PNH and LGL or MDS. There are also new entities such as VEXAS, where we identify patients with rheumatologic diseases that also have an underlying MDS, or it could actually be multiple myeloma. And there's a specific mutation that identifies this disorder. So we're doing a much better job at identifying what the drivers are to some of these co-occurring disorders. So this slide highlights what I just walked through, that sometimes these mutations have beneficial effects. But we know, and what we're focused on today, is that these mutations can also be associated with a higher risk of hematologic malignancies, and specifically referring to myelodysplastic syndrome, AML, and others. And so this risk for patients, if the mutation is present for patients over the age of 70, there's a tenfold risk of hematologic malignancies. So what does that mean? What is MDS exactly? It seems like a pretty fancy term and a medical term that's hard to relate to. But when I talk about it with patients and caregivers, I often describe it as the bone marrow cells are just looking funny. And that's the word dysplastic, and myeloid is referring to the cells, whether they're the white cells. Often we talk about myeloid cells being white cells, red cells, or platelets. Here you're seeing cells that look wonky under the microscope, and I should improve my slide by having what normal looks like, so that when I show you abnormal, you kind of get what I mean. But many of these cells have this open chromatin that looks like it's lots of puffiness going on within this cell. Or even there's multiple nuclei or two of these nuclei in one cell. So these forms, or even four, you can see that this is just not normal. The analogy I talk about is a chocolate chip cookie factory. So the bone marrow factory is producing red cells, white cells, and platelets. In your chocolate chip cookie factory, you want your cookies all to be the same size, and you want the same number of chocolate chip cookies. And if your chocolate chip cookie factory doesn't have chocolate chips, then your cookies are dysplastic, and we don't want dysplastic chocolate chip cookies. So that's kind of a simple analogy that I use. We also are highlighting here in the lower right-hand corner these cells that have blue stained iron around them, and these are called ring sideroblasts. These ring sideroblasts are red blood cell precursors or erythroid precursors with abnormal perinuclear mitochondrial iron accumulation. So it's actually marking the iron that's around these cells. And the definition by pathologists in order to call it a ring sideroblast means that there has to be 5 granules covering at least a third of the circumference of those cells. And the reason why this is important is because we often see ring sideroblasts associated with a specific mutation called SF3B1, and you'll understand why this is important later on in my talk. But the iron is deposited in the perinuclear mitochondria of the ring sideroblast is present in the form of mitochondrial ferritin. And we know that this can happen when cells are stressed out. The presence of ring sideroblasts doesn't mean that it's 100% MDS. You can have other reasons for a stressed out marrow, such as drinking too much at somebody's wedding, right? or having lead or zinc toxicity, copper deficiency. So there's lots of things that we spend a lot of time making sure that we understand there's not nutritional deficiencies, rheumatologic disorders, or other types of things. And once we've ruled out all of those other things, then we start turning to, hey, maybe there really is an underlying myelodysplastic syndrome. Usually, though, if we see these cells, it means that the bone marrow factory is not making red blood cells the way that it should, and we're having ineffective production of red cells. As Dr. Scott talked about, there's two ways to describe for pathologists or classify MDS through this WHO classification system or this ICC classification syndrome, ICC classification system. This one is an outdated one. There's now a 2022 classification system. Nonetheless, the ideas and the things around the classification are important. Dysplasia, or the cells looking funny, has to exist at least in one cell line to greater than 10% of the cells. And if that's not there, then the bone marrow is not diagnosed or classified as dysplastic. Additionally, there's lots of other chromosomal changes, such as the deletion of chromosome 5, that is pretty classic and is more likely to respond to drugs such as lenalidomide. And that's an important thing that we'll move to when we talk about therapies. Additionally, I highlighted the fact that these ring sideroblasts are often associated with the presence of this SF3B1 mutation, and that mutation is one of the only mutations that's associated with a good risk MDS. So these patients tend to have a longer duration and do much better for a longer period of time. Counter to that are the higher risk MDS patients that have higher blasts, as Dr. Halpern talked about nicely, and also can have higher risk mutations such as TP53. Years ago, the classification system never even included mutations as part of their classification and analysis. And now we've moved to including some of these mutations to help us better classify these disorders. And as a part of that, we're able to refine the diagnosis, and then potentially for each particular phenotype, we're able to direct therapies that may be most effective for those phenotypes. And I think that's really the dream. We're trying to get the best therapies for the best patient phenotype in the upfront setting to the best of our ability. You've already seen this scoring system. So when I have a patient that comes to me as a new patient, we use this mechanism called the International Prognostic Scoring System. The first one was done by Dr. Greenberg. Subsequently, this has also been improved by not only including the chromosomes, the blast percentage, and the number of cell counts affected, but now we're being very detailed about what is the exact number to the hemoglobin, what is the exact number to the platelets. And now with time, we're including the mutations. So the IPSS was the first version. The IPSS-R is the IPSS-R revised version. And then the IPSS-M, which I'll talk about, is the one that incorporates mutations into this system. So there are different points for different places with regard to the numbers. And then based on the total point number, we can get a better sense of whether or not the patients are presenting with a lower risk disease or higher risk disease. Why is this important? We've talked about shared decision making. If a patient knows that they're in a low risk situation, then we can talk about supportive measures, and we may not need to start therapy imminently. Whereas if we have a high risk MDS, we may want to start therapy to delay progression to acute myeloid leukemia, and to also have influence and discussions about whether or not a bone marrow transplant is possible. Importantly, the International Prognostic Scoring System helps us to look at whether patients have a low-risk disease or a high-risk disease with regard to survival. And just as Dr. Halpern talked about, it also helps us to understand what's the freedom from AML evolution. So we worry more about those patients that are in high and very high risk, that those patients are going to progress sooner to an acute myeloid leukemia. And we know that the therapies that we have help us to delay that progression and have an influence in that. And again, the three things that we use for that scoring system include the percent blasts in the bone marrow, the chromosome changes, and the number of cell lines affected, and how deficient those cell lines are in terms of needing support. This is a diagram to just highlight and bring us back to some of the fact that these mutations can exist. Sometimes these mutations don't do anything and patients don't progress to MDS or to AML. Sometimes these mutations exist and patients go through this whole pathway of clonal hematopoiesis, myelodysplastic syndrome, and progress to AML. And then other patients can go straight to MDS or can go straight to AML without going through this pathway. And there's still we're still trying to figure out why there's these different pathways and what genes are ones that we worry about. We've highlighted the fact that inflammation and aging can put patients more at risk for progression to myelodysplastic syndrome. And later today, Dr. Keel will talk about genetic predisposition states where there's certain mutations that we understand to be familial and put people more at risk in their families for these types of disorders. In general, we know that these mutations have an impact on clinical outcome. As we talked about, there are certain mutations that are better risk mutations where they're favorable, and a whole host of genes that I'm not expecting you to remember, other ones that are associated with a highly resistant clone and very difficult to treat. We also know that the more mutations that are there in the MDS, the higher, the worse the outcome is for those patients, both in overall survival and leukemia-free survival. This again, you've seen now 3 times. This is the IPSS-M, which tells us, hey, can we incorporate some of the mutations into the scoring system to help us better understand and better refine this ability to predict who's going to do well and who isn't going to do well. And I would say it's really important to know that upfront. That information is paramount to making decisions about therapy, about transplant. And so the better models we have, the better we can make decisions about whether to move forward with therapy or not. So hopefully, I've driven home the point that these mutations matter. They underscore the heterogeneity of MDS, whereas some patients can do well for a long period of time. If that's the case, I want to know that. I want my patients to know that. And if there's an MDS that's a higher risk disease, we want to know that so we can do something about it. These mutations help us identify germline risk. They help us with prognosis, as we've talked about, and it also can help us with treatment selection, as Dr. Halpern talked about, with specific mutations that have targeted therapies that can go to that mutation and directly target the cells, the malignant cells themselves. We're still working on, can we detect disease at a low level? And that's called measurable residual disease, even for patients after transplant. So there's lots of things that we can now do that we didn't have years before. So now I'm going to turn quickly to the treatment goals in MDS. First off, of course, we love to talk about cure. And I think one of the next talks will be about bone marrow transplant. Obviously, we want to improve overall survival, lower the risk of transformation to AML. We want to talk about and work towards complete remission, or CR, as we heard about, or partial remission or stable disease. We want to look at and improve trilineage hematopoiesis so that patients are not reliant on transfusions. And we also want to decrease the symptom burden that impairs the quality of life for our patients. So again, some of this is really shared decision making with your physician and figuring out what are the goals of therapy and how can we best meet those goals. Since 2006, there have been new drugs that have been FDA approved. You can see that there was almost a 20-year gap where there were no drugs that were FDA approved for MDS. And that has changed in the last 5 years, which is amazing to witness and amazing to see. And I think a lot of that has to do with the innovations in pharma and also just the better understanding of the pathogenesis of the disease. And we'll walk through each of these agents, but you already heard earlier about azacitidine and decitabine from Dr. Halpern, as well as lenalidomide. And today, well, I'll be spending a little bit more time talking about luspatercept, ivosidenib, and imetelstat. Again, the treatment options for patients with low risk MDS could be observation, watching and waiting, supportive transfusions. If patients get lots of transfusions, we often will turn to chelation to remove excess iron. We talk about ESA-based therapy, and Dr. Halpern walked you through some of these agents as well, where we're stimulating the red blood cells to grow. Or we can also use immunosuppressive therapies where the immune system is attacking the bone marrow factory and decreasing its ability to produce chocolate chip cookies, right? We also have these immunomodulatory drugs such as lenalidomide. and luspatercept and imetelstat. For low-risk MDS patients, we rarely recommend a bone marrow transplant unless there are mutations or other pieces about that particular disease that we need to address. Here's a general treatment algorithm for our patients with lower risk MDS. And you can see that, I don't know how to go back. You can see here that many patients are symptomatic, and most patients, as I talked about, have an anemia or a low red blood cell count. And we talk about using transfusions. For many patients that have a deletion of 5q, we start a medication called lenalidomide, which is an oral drug. And for those patients that have a low erythropoietin in their serum or their blood, we start a drug called erythropoietin stimulating agents, and we'll talk more about this. There are other options for patients that have a low platelet count or a low neutrophil count that puts them at risk for infections. And then some patients have all three cell lines that are low. And in that situation, we often turn to azacitidine or decitabine based therapies, as we talked about earlier. When we talk about supportive measures, here's a outline of some of the types of transfusional support that we recommend. And typically we have boundaries of if the hemoglobin is below 8, many patients are symptomatic, and therefore we then offer transfusions. We often irradiate products and leukoreduce them. So those are important things that if you're getting a transfusion, you want to know about. I'm not going to talk much about iron overload today, but this will be a resource for you if you want to take a look at it. We also highlighted these erythroid stimulating agents. We know that anemia is present in the majority of patients with MDS. And we know that this type of therapy can improve the hemoglobin levels and reduce transfusion needs. And that if patients respond to this therapy, it can last for up to 2 years in terms of response. The majority of responses occur within the first 2 months of therapy. And if patients haven't, if their marrow hasn't responded to these therapies, we typically then recommend stopping them. And then the other important piece to this is that treatment with erythroid stimulating agents does not increase progression to AML, so it's safe to use these agents. We actually have a scoring system that helps us to understand who is more likely to respond to ESA-based therapy versus not. If you know that your disease is in a place where it's not likely to respond to this agent, let's not use those 2 months of therapy, expose patients to those agents if we have a very low risk of response. So having this type of tool can be really important to spare patients the toxicity to agents and also move to therapy that is effective and can work. I talked a little bit about lenalidomide, and we know that this is a drug that's FDA approved for those patients with MDS that have a chromosomal deletion of the Q arm of the chromosome and deletion 5 in chromosome 5. We know that this particular drug, lenalidomide, it improves decreases the need for transfusions, and that can last for up to 2 years or more. Patients can have an increase in their hemoglobin level by 3 grams, and the time to response takes about a month at least on the drug to have a response. It can be a challenging drug because it causes the counts to be low. This is a picture of 2 of the studies, the MDS 002 and 003 study that was done by Dr. Alan List, where patients received 10 milligrams orally of this drug for 28 days or for 21 days. And you can see that the transfusion independence happened in about 60 to 70% of patients that took this pill. About 67% of patients no longer needed transfusions by week 24. And there were no significant difference in response rate between the 2 treatment schedules, and the median time again to transfusion independence was about a month. Dr. Santini decided to look at this same drug in patients that did not have a deletion 5q and found that about 25% of patients had transfusion independence, and the duration of transfusion independence lasted about 32 weeks. So this is also a meaningful drug for patients, mostly for deletion 5q, but can be used in patients that have MDS without deletion 5q as well. The challenge in terms of the side effect of lenalidomide is it can cause the platelets to be low, and this can mean that we need to dose modify. We can also use drugs that cause immunosuppression, such as prednisone or steroids, or this other drug called ATG. There are other types of immunosuppressive therapies that are called steroid sparing, where we use a drug that suppresses the immune system, but it's not prednisone because prednisone has a lot of side effects to it. So we use drugs that are often used in the transplant setting, such as tacrolimus or sirolimus. And so these drugs in general, the complete response to them, looking at this meta-analysis, was about 11%. But many patients had improvement in their hematologic response, about a third of them, and about a third of the patients had stabilization of their disease with an overall response rate of 50%. So this is an important modality that is often overlooked in the treatment of MDS. I'm now going to turn to luspatercept, which is an agent that is really important and just recently approved in the last 3 to 4 years. Luspatercept binds to select TGF beta superfamily ligands and decreases what's called SMAD signaling. And this is a baby erythroid cell or a baby red blood cell that needs to mature into a functional red blood cell. And what happens in MDS is this pathway is disrupted by an increase in SMAD signaling, an aberrant increase in SMAD signaling. So this particular drug, luspatercept, attacks that pathway and allows the normal maturation of the red blood cell. So this drug was studied in patients with low risk MDS that were transfusion dependent in both ring sideroblast positive and non-ring sideroblasts. And the same was true with mutation or non-mutation with SF3B1. And you can see about a 70% likelihood of transfusion independence for patients, or excuse me, improvement in the hemoglobin, and about a 40% likelihood of transfusion independence. When this case study came to fruition, it then started the Medalist study looking specifically at only patients that had transfusion dependent MDS that had ring sideroblasts or SF3B1 mutations. And they then found that this actually was a very important drug in those patients. And these patients also on this study had previously been exposed to ESA-based therapy and hadn't benefited from it. This led to the FDA approval of luspatercept for those patients with MDS that had ring sideroblasts or SF3B1 mutated disease that had no longer benefited or responded to ESA-based therapy. As a result of the fact that the PACE study also showed very interesting or promising results in those patients without ring sideroblasts and without SF3B1 mutations, another study called the COMMAND study decided to look at the upfront use of luspatercept in patients with MDS that had not received ESA-based therapy and wanted to actually use luspatercept versus ESA-based therapy. This is the prior Medalist study that we already talked about. But in this COMMAND study, it was all patients with low risk MDS. And you can see that these patients were upfront receiving either luspatercept or ESA-based therapy. And they were looking for which of these two drugs was better in reversing transfusion dependency. And you can see here that there was a lot of promise with regard to luspatercept over the ESA-based therapy for patients in terms of decreasing transfusion independence and also improvement in the red blood cell number. The time to the first transfusion for luspatercept was 169 days and 42 days for ESA-based therapy. The primary endpoint of this study was shown to be a decrease in transfusion burden as well as an increase in hemoglobin. And this was met more frequently in those patients that had received luspatercept at 58.5% versus those patients that received ESA-based therapy at 31.2%. Importantly, you'll see in the red highlight here that to the left of that, you can see those patients with ring sideroblasts did much better. 64% of those patients got transfusion independence compared to those patients that received ESA-based therapy. But for those patients without the presence of ring sideroblasts, it didn't matter whether you got luspatercept or ESA-based therapy, you still had about a 40% likelihood of transfusion independence and improvement in your hemoglobin. So these details matter. This study in particular enrolled more patients with ring sideroblasts, even though it was for all comers. So understanding that study, we don't still really know which one is better in the upfront setting, but I would say it probably wouldn't matter for those patients that have ring sideroblast negative state. Both of those agents should be equally effective. Now I'm going to turn to a new drug that recently got FDA approved this month. Big deal, right? Imetelstat is a first-in-class telomere inhibitor with disease-modifying potential. It is a direct and competitive inhibitor of telomerase activity, and we believe that the malignant cells are more likely to have this activity going on. They're more likely to be affected by and impacted by inhibiting their telomerase activity, and it causes these malignant progenitor cells to die and allows for recovery of red blood cells, white blood cells, and platelets. In this study called the IMerge study, it was a phase 3 study where patients were enrolled in this study. The difference from the prior studies is these patients had a higher transfusion burden. They were still low risk MDS patients, and they could not have received lenalidomide or azacitidine prior to enrolling in this study. Patients were randomized, 2 patients to every 1 patient on placebo, and the primary endpoint again being transfusion independence. Here you can see in the blue for those patients that received imetelstat versus those that received placebo in the yellow. The majority of the patients here, you can see 39.8% of patients had transfusion independence after receiving imetelstat and had 8-week transfusion independence, 16-week transfusion independence for 31% of patients, 24-week transfusion independence for 28% of patients, and then at 1 year, 13.6% of patients on the imetelstat, compared to those patients with placebo in the yellow bar. This was very meaningful. You can see that those patients that were actually responding to imetelstat had a longer duration of transfusion independence compared to those patients that were receiving placebo. And another way of showing that is showing the significant and sustained increase in hemoglobin among patients treated with imetelstat. In general, you can see a rise in the hemoglobin of 3.6 points. And it's important to notice that it took 2 months to get to that actual benefit of imetelstat. So patients had to be on this therapy for quite some time. The challenge with this drug is that it can also cause cytopenias. Here you can see again the same plot, 0 being, or here being a direction where it favors placebo, and to the right where it favors imetelstat. For every subgroup that was evaluated, there was benefit in receiving imetelstat versus placebo. So this drug recently was FDA approved this month. Walking through this, the important safety considerations are that it can cause grade 3 to 4 neutropenia and thrombocytopenia, so we need to follow the counts. And actually, if the drug is held, those cytopenias improve. One of the limitations is that this was studied in patients that were not previously exposed to luspatercept. So we don't exactly know what the real rate of response is in those patients that had previously received luspatercept. Now I'm going to turn quickly to hypomethylating therapy or drugs such as azacitidine, which are used in patients with high-risk disease. There were questions about whether or not we should use these lower doses with lower duration in patients with low-risk MDS. And so there was some response for patients that received either 3 days of azacitidine or 3 days of decitabine. And many of these patients did better when they received decitabine, although the dosing was a little bit more heavy-handed in those patients that received decitabine. So this can be an option, although it does actually have some toxicity to it, and you need to be managed carefully with your physician. For patients with high-risk MDS, Dr. Halpern kind of walked through a lot of this, which I'm grateful for. I don't need to go over too much. In general, with hypomethylating therapy, about 40% of the patients will have some response, with about 17% complete response, and the duration of that response being 9 months, with an overall survival about 13 months while being on these therapies. We know that transplant does better in patients that have high-risk MDS. You can see for those patients that receive a reduced intensity transplant versus no transplant in low-risk patients, they do better with just getting therapy and monitoring. And for those patients with high-risk MDS that do get transplanted, there's a survival benefit in going to transplant. And there are data to show that those patients that are between the ages of 50 to 75 years of age that have a donor option, they benefit from getting a bone marrow transplant. And this is very important data that I'm sure will be highlighted in the transplant discussion. Here you can see what is the outcome for patients that receive azacitidine with high-risk MDS versus a conventional care arm of chemotherapy or best supportive care. There was a benefit of 9.4 months for those patients that received azacitidine, with an overall survival as you see here. Patients also received in another study that mimicked the same kind of plan with azacitidine, but instead of getting azacitidine, they received decitabine and were randomized to decitabine in the yellow arm versus best supportive care. We have a lot of challenges with regard to best understanding what the CR rate is with these hypomethylating agent. We think it's somewhere around 7 to 32%. With regard to dosing, it's important to administer it for at least 4 to 6 months. There are side effects, but they are manageable. The other pieces that are important is that older patients, even up to the age of 80, can get these therapies and tolerate these therapies. And we often need to sometimes delay the doses, particularly after 6 to 9 months, just because the marrow gets a little tired. But initially, we try not to do any kind of doses that are altered or drug holidays. We favor kind of dose reductions rather than the drug holiday. We know that responses are slow. We know that responses are associated with improved survival. And as I mentioned, elderly patients can tolerate this therapy. We don't entirely know why the responses are slow. And I think, we have clear evidence that responses are improved with overall survival, but we're not entirely sure why that's the case and why it's more impactful in the erythroid lineage or than the white blood cell lineage. So we know there's some interactions, but I'm not sure we entirely understand some of the pathogenesis, and I think more of us are leaning into that from a research standpoint. And then I also wish we knew which patients were more likely to respond to these drugs. As we highlighted, 100% of patients that take these agents are not responding. It's only 50% of patients. So if we could really identify who's going to respond to these therapies and spare those patients the toxicity and exposure to these drugs, that would be far better. We know that the survival for patients remains poor despite these agents. So we're really working towards combining these agents with other agents such as IDH inhibitors or even venetoclax, which you heard Dr. Halpern talk about earlier. And a lot of work right now is going into looking at menin inhibitors. There have been a number of phase 3 studies in the upfront setting for patients with high-risk MDS. And I'm saddened to say that these 3 phase 3 studies have not led to finding any benefit for patients with high-risk MDS. So these studies have now really shut down. The Verona study is a study that Dr. Halpern talked about earlier, where newly diagnosed high-risk MDS patients are randomized to either azacitidine plus venetoclax, which is this BCL2 inhibitor, versus placebo plus azacitidine. And this is some of the data that highlight why that study was done, showing that the overall response rate for patients on this combination study was 80%. And we're excited to see what that study will show and very eagerly awaiting its results. Here are some of the other agents that we may have already touched on, such as targeted therapies with IDH1 or even venetoclax. Dr. Halpern already talked about induction 7 and 3 versus a drug that's liposomal called CPX351. And I'll highlight just a few things about these particular targeted therapies, primarily because we use these therapies for patients that are diagnosed with AML. And you can see that the response rates for those patients with AML have led to the FDA approval of these agents for patients, and we're hopeful that we can use these drugs in patients with MDS. We know that these mutations exist in patients with MDS in about 10% of the time, and there have been 2 studies looking at IDH1 inhibition and IDH2 inhibition as well. And I'll walk through briefly for those patients with MDS. There were 3 cohorts: higher risk MDS that no longer are responding to AZA-based therapy, that get this oral pill that targets their IDH1 mutation in their disease, or higher risk MDS patients that have not received any therapy that receive this pill every day for 28 days, or lower risk MDS patients who no longer are responding to ESA-based therapy that receive this oral pill. Now, these patients were, if they responded, they continued to get the drug. If they did not respond to and were treatment naive, they got the combination of the pill plus azacitidine. And patients were evaluated until progressive disease. Now, ultimately, you can see here for those patients that had not received any other therapy, an overall response rate to this pill was 91%. Pretty amazing. For those patients that had low risk MDS that had not been responding to ESA therapy, overall response rate 50%. And then for those that had previously been exposed to AZA-based therapy, an overall response rate of 54%. The dark blue being complete remission, light blue being hematologic improvement or partial response. Ultimately, this drug was these studies led to the FDA approval of ivosidenib, which is an IDH1 inhibitor for relapsed refractory MDS. And so again, just highlighting the importance of testing all of these disorders for the presence of mutations, because if you have an actionable mutation, you can take a pill. Gosh, those response rates look pretty good. They did the same studies looking at enasidenib, which is a drug that targets IDH2, and I'm not going to go through the design, but it's very similar to what we walked through. In the first line setting, 56% overall responses for those patients with high risk. This is off kilter a little bit. So the high risk MDS is over here. Sorry about the off kilterness here. And the overall response rate being 50%. So this is also very exciting. And you can see patients here with another study looking at overall response rates in patients with enasidenib in second line versus first line. There are some emerging therapies. Oral azacitidine, however, led to a lot of toxicity and issues with infection. So this study was halted, and we don't know the best version of this oral azacitidine pill. And we may not be incorporating that in patients with MDS as a result of that, or we'll have to figure out what the best dosing is in the management. CPX 351 is that liposomal agent that Dr. Halpern talked about, with very exciting response rates in patients with high-risk MDS. And what's important about this is they use this as a bridge to transplant. The majority of these patients, you can see 29 out of 31 were successfully able to go to transplant. We also have immunotherapy that is being investigated and not yet approved for MDS, so things on the horizon that are investigational, and also novel agents that are targeting the inflammatory pathways such as CXCR1 and IRAK4 inhibitors. Here's a summary of what we just walked through with regard to high-risk MDS, and it will be a segue into the next talk that focuses on bone marrow transplant and transplant eligibility for those patients. I think the most important thing, though, is that hopefully we've highlighted the importance of clinical trials for patients that are diagnosed with MDS and the importance of that, mutational analysis, how important that is in any patient that's diagnosed with myeloid diseases. And with that, I'll thank you for your attention.